Hi everyone. Today's topic is on epidemiology and public health aspects of dental caries. Learning outcomes. At the end of the topic, the student should be able to summarize the current trends in epidemiology of dental caries, illustrate the roles of factors in etiology of dental caries, infer the findings of dietary studies on controlled human population, plan preventive strategies for control of dental caries at individual and community levels. First of all, what is dental caries? Dental caries is defined as an infectious microbiologic disease of teeth that results in localized dissolution and destruction of calcified tissues. The word caries is derived from Latin meaning rot or decay. It is similar to Greek word cur meaning death. Relationship between diet and dental caries. We know our oral cavity consists of many bacteria, and when we have food, definitely that food flecks will be accumulated on our teeth. That is called plaque. So bacteria will always produce enzyme. So bacterial enzyme plus fermentable carbohydrates through the food will produce acid. So that acid affects on the enamel. So enamel will dissolve in the acid and it form caries. So in the previous topic we have decided about epidemiology. That was general epidemiology. Now we are studying about epidemiology of dental caries. So dental caries as a disease of modern civilization. Population that had not acquired dietary habits of modern like industrialized man retain a relative freedom from dental caries. That means primitive people were not showing much dental caries or no dental caries. But modern people are showing much dental caries. Maybe due to our dietary habits. So we will see how the dietary habits are playing role in dental caries causing. So current trends in dental caries. This is in Malaysia, which is taken from moh.gov.my. Among the 5-year-old, in 1995 it was 87.1. In 2005, it was 76.2. In 2015, it is 71.3 among 5 years old. Coming to school children of 12-year-old, in 1988, it was 71.3. In 1997, it was 60.9. In 2007, it is 41.5. In 2017, it is 33.3. So, looking at these values, one can conclude that the prevalence of dental caries is going down. In the adults also it seems like in 1990 it was 94%, 94.6. In 2000 it is 90.3. In 2010 it is 88.9. So in all the age groups it's showing decrease in dental caries prevalence. So coming to theories of caries etiology. So, early theories of caries formation, it was the old people were thinking like our ancestors, the dental caries is caused from worm. Worm is the cause of tooth decay. But as the evolution takes place, then they thought endogenous theory. In that humoral theory and vital theory. According to humoral theory, the four elements of humors in the body were blood, phlegma, then black bile and yellow bile. So dental caries is caused by internal action of acid corroding humors. So that was the belief. Later, vital theory came. In that, vital theory of tooth decay states that decay originated like bone gangrene from within the tooth itself. So we should think how people thinking capacity is increasing day by day. Then exogenous theory comes. In that chemical acid theory, Robertson proposed that dental decay was caused by acid formed by fermentation of food particles around the teeth. Here, microorganism presence was not yet recognized. Then comes parasitic or septic theory. by Antony van Leeuwenhoek indicates that microorganism associated with Carey's process. But Dubos postulated that microorganism can have toxic effects on tissues. Then the person called the scientist Miller's chemoparasitic theory. According to him, many microorganisms in oral cavity can produce acid, that is lactic acid, from fermentation of sugar were responsible for tooth decay. He also showed that extracted teeth could be demineralized when incubated in mixture of bread or sugar within human saliva. So he is almost near to the etiology, but still we don't know exactly what are the etiology for dental caries. Then coming to Stephen Kerr. Stephen showed that within 2 to 4 minutes of rinsing within solution of glucose or sucrose, plaque pH is reduced from about 6.5 to 5 and gradually returns to original value within approximately 40 minutes. So that are all the theories. So now we will study what are the etiological factors of dental caries. First is a susceptible host tissue, which is that tooth. Then a microflora with cariogenic potential, that is bacteria, and a suitable local substrate, maybe saliva, food. So we in detail will study in further slides. A susceptible host tissue means a tooth. So morphological characteristics will influencing the initial decay like deep pit and fissures. So if you have deep pit and fissures, it is prone for dental decay. And malaligned tooth, like irregularly placed in the arch, tooth are irregularly placed. So that will cause dental caries because accumulation of food will be more. Once food is there, then plaque formation, then bacteria will produce their bacterial toxin that will interact with the enamel and enamel dissolution, then decay. Coming to saliva, this is also an host component. Study of saliva and its tooth protective components reveals at least 4 important functions of saliva. First is buffering ability, cleansing effect, antibacterial action, maintenance of saliva supersaturated in calcium phosphate. Salivary antibacterial substance. Saliva consists of lactoperoxidase, lysosomes, lactoferrin, IgG. Actually, I still remember my grandfather used to tell, don't spit, you just swallow it. Even though, like saliva, we should not spit because it contains all these things. We have to swallow. Only thing, like if some bad taste and something which is unacceptable to us, then only we have to spit. Or else, we have to swallow the saliva. So, coming to the function of lactoperoxidase, it has a high affinity for the enamel surface and it forms an important defense mechanism limiting early microbial colonization of tooth surface. So, it's protective. Then, lysozyme, it is a small, highly positive enzyme that catalyzes the degradation of the negatively charged peptidoglycan matrix of microbial cell wall. So, it's somewhere it's inhibiting the bacterial uh, production or the actually it's causing the death of the bacteria. Then lactoferrin, it is iron binding protein found in the saliva which limit the amount of free iron needed for bacteria. See, bacteria needs some certain amount of iron. When lactoferrin enzyme is there, it will bind the iron, so free availability of iron is not there, so bacteria won't get that iron, so it will die. So this is somewhat protective in nature, or it is preventing the dental caries. IgG, I think you have studied in your second year about the immunoglobulins. It is an agglutinin which inhibits the adherence and thereby prevents colonization of mucosal surfaces and teeth by organism, facilitating their disposal by swallowing. So this is straightforward, no need of explanation. Microflora within the cariogenic potential. The role of microorganism in caries. Microorganisms are prerequisites for caries initiation. So there should be a host in between. With that, we should have like microorganism. A single type of microorganism is capable of inducing caries. So Some microorganisms are only causing the caries. Then the ability to produce acid is prerequisites for caries induction, but not all acidogenic organisms are cariogenic. Streptococcus strains that are capable of inducing caries are also able to synthesize extracellular destrans or levins. Then organisms vary greatly in their capacity to induce caries, which forms just prior to or concomitantly with bacterial colonization and may facilitate plaque formation. The microbiology of dental plaque includes three groups of microorganisms, namely Streptococci, Actinomyces, and Veillonella. Then, streptococcal mutants considered to be the chief etiological agent in dental caries. There are two types, extra and intracellular. So, intracellular is responsible for dental caries. Then, cariogenic plaque forms more lactic acid from stored intracellular polysaccharide. Then cariogenic plaque forms approximately twice as much extracellular polysaccharide from sucrose as do non-cariogenic plaque. So non-cariogenic plaque will have intercellular polysaccharide. Properties of cariogenic plaque will be continued. Like cariogenic plaque contains higher level of streptococcal mutants than non-cariogenic plaques. Non-cariogenic plaque harbor higher levels of Streptococcus sanguis and Actinomyces than cariogenic plaque. Non-cariogenic plaque have significantly higher properties of dextranase at producing organisms. Non-cariogenic plaque have higher level of Veillonella and slightly lower concentration of lactic acid. So these are the characteristics of plaque. A suitable local substrate. Physical properties of food and cariogenicity is retentive ability of the host to food. Like physical nature of the diet, modern diet is refined tend to increase caries activity. Carbohydrate content of diet, important factors to cause decay. For example, deficiency of vitamin D. Vitamin A, D affects development of caries because vitamin A and D is responsible for tooth development. So once the tooth development is not properly happened, then there will be an deep pit and fissures that will lead to dental caries. Then vitamin B complex. It alters the oral flora by increasing the non-cariogenic activity and suppress the cariogenicity. Then comes the fluoride. I think you will be knowing. Yeah, because you know like fluoride is inhibiting the caries and our toothpaste contains fluoride. Even Malaysia have water fluoridation that we will discuss in fluoride topic. So this is an epidemiological triad like microflora, host, diet, and most important factor, time. So if diet is not proper and microorganism is there and there is a pit, in one day dental caries won't be showing the incidence. It should need certain time. So new dental caries, if it's forming, means it needs minimum 3 to 4 months. Coming to demographic risk factors, the age. Increase in chronological and dental age can be considered an indicator of more intense caries experience of first permanent molars and for a medium and deep caries lesions. For lower chronological ages, superficial caries lesions are more commonly detected. So this is the reference for that. Then the gender. Females are typically found to exhibit higher prevalence. I have referred many articles. In most of the articles, females have more prevalence of dental caries. Then the race and ethnicity. African descents were 32% more likely to have caries experience than whites. Mixed race were 69% more likely to have caries experience than whites. Hierarchically, conceptual modeling analysis confirmed the highly significant association between caries and race ethnicity. So, our prevalence of caries will also associate with our race. Socioeconomic status. Low socioeconomic status, low monthly household income, and low education level are associated with the less access to dental services and oral hygiene products, poorer knowledge regarding oral health and oral hygiene, and consequently a greater frequency and severity of dental caries. Familial and genetic pattern. Genetics accounts for up to 65% of inter-individual variation in dental caries experience. Some genetic DNA which will run in the families. That exact name I was unable to find, but this study has proven like the dental caries will spread in genetical individuals, like in the families it will run. Evidence from human intervention studies. Studies very less problem of pursuing groups of people to maintain rigid dietary regimen for a long terms period, and some are unethical because after Helsinki Declaration we can't many ethical issues will come. So these studies they have done before this Helsinki Declaration. Some of these studies are done before Helsinki Declaration, and that studies have proved like how the diet is in relation to the dental caries. Like Vipeholm study, Hopwood House study, TURKU sugar study, hereditary fructose intolerance, and seventh day Adventist study. So these are some of the diet related studies which is proving if you vary the diet, dental caries also vary, and incidence of caries is high with some intake of food or dietary habit. Coming to Vipeholm study, it was conducted by Gustafson et al. In 1954. Purpose to determine the effects of frequency, quantity, and physical form of sugar intake on the formation of dental caries. It was done in institutionalized patient. 6 experimental and 1 control group were there. See here, institutionalized patient. That means they are hospitalized or they are in old age homes. So there are 6 experimental group and 1 control group. See, if you are giving treatment, you have to give treatment to everyone. That's what ethical issue comes. So after Helsinki Declaration, this kind of studies we were unable to do. So 7 experimental group, like in the left hand side it's a group and the right hand side it was an intervention. Control group like usual diet, and there is a sucrose group, that is 300 gram of sucrose in solution and 75 gram in last 2 years. This study was conducted for around 10 years. In the first 7 years they have given 300 gram like that, in last 2 years 75 gram. So bread, 345 gram of sweet bread, 50 gram of sugar daily. In the chocolate group, 65 gram of milk chocolate daily between meals for last 2 years, and caramel groups, 22 caramels is equal to 17 gram of sugar in 4 proportion between meals, and 8 toffee, that is 8 sticky toffee is equal to 60 gram of sugar daily for 3 years, and 24 toffee, which is 24 toffees, 120 gram of sugar for 18 months. Conclusion from Vipeholm study. It was conducted between 1946 to 1952, so it will be around 7 years. An increase in carbohydrates, mainly sugar, definitely increases caries activity. The risk of caries is greater if the sugar is sticky in nature. The caries activity is greatest if the sugar is consumed between meals. Increase in caries activity varies widely between individuals. Upon withdrawal of the sugar, rich foods increase activity, rapidly decrease and disappearance. High concentration of sugar in solution and its prolonged retention on tooth surfaces leads to increased caries activity. This study showed that physical form of carbohydrate is much more important in cariogenicity than the total amount of sugar ingested. Coming to the second one, that is Hopwood study, which was conducted in New South Wales, Australia, among 80 children aged between 7 to 14 years for a 10 years period. Australian Children Home Hopwood House compared the effects of lacto-vegetarian diet to that of average Australian child diet on dental caries activity. Diet fed a diet of whole meal bread, soya beans, oats, rice, potatoes, fresh juice, root and green vegetables, and salad, nuts, and porridge. Between the meals, only fruits or fruit juices are given. Children encouraged to drink plenty of water, pure and fluoride free. Treats consisted of hopwood lollies, fed little meat. Nutrition agreed that diet was sufficient of all crucial method. It's a 10-year survey. That's why I was confused. The previous one whiteboard was 7 years. This is 10 years. The annual clinical examination were conducted and radiographical examination were done and collection of saliva samples. Results. Hopwood children had 16 times less decay than other Sydney children of the same age. Sydney children had an average 9.5 decay, missing or filled teeth per child. There was only 0.58 in the Hopwood children. Conclusion. Diet play an important role in the formation of caries. Dental caries can be reduced even without the beneficial influence of fluoride and in the presence of unfavorable oral hygiene. Then comes the TURKU sugar study. It was done in Finland. Participants are 125 subjects of all the age groups. Objectives to find out the effect of diet total sucrose free on dental caries increment. There are 3 groups in this study. First group, this chewing gum containing fructose with 35 samples. Second group, 38 samples chewing gums containing sucrose. Third group, 52 samples chewing gums containing xylitol. Results, a dramatic reduction in dental caries after 2 years in the xylitol group. And caries reduction is better with xylitol than fructose. Seventh-day Adventist children study, they had certain restriction in their diet, which is included the limitation of sugar sticky elements, highly refined starches, then between meal snacking. All these studies showed that level of dental caries was much lower in the Seventh-day Adventist group compared to the other children. Hereditary fructose intolerance. Genetic defect, the individual affected cannot tolerate fructose or sucrose. Ingestion of fructose or sucrose causes nausea, sweating, convulsion, may lead to coma and death. Affected people learn to avoid all foods containing sugar and fructose, although they are able to consume starch. Persons with hereditary fructose intolerance shows a strikingly reduced dental caries experience when compared to a control population of same age. Trace elements and dental caries. A study conducted by Hagimarkos revealed that caries experience increased with increasing concentration of selenium in the water supply and foodstuff. The caries experience was inversely related to the concentration of vanadium by Tank et al. In 1960, strontium and molybdenum. So these are the trace elements. A review by Nevia et al. In 1972 revealed the effect of various trace elements. For example, the caries promoting trace elements are selenium, magnesium, cadmium, platinum, lead and silicon. Mildly karyostatic are molybdenum, vanadium, strontium, boron, calcium and gold and lithium. Definitely karyostatic, fluorine and phosphorus. No effect are aluminium, iron, barium and nickel. Doubtful effect, manganese, cobalt, zinc and bromine and iodine. Measurement of caries indices. Used to know number of person affected, number of teeth need treatment, number of surface inward, number of teeth have been treated, number of teeth missing due to caries, DMFT index, DMFS index, DEFS index, caries severity index. These are some of the indices used to measure the caries. Diagnosis of caries. Inspection, palpation, radiographs, diagnodent lasers or caries activity test. I think this will be covered in your endodontics in detail. Methods of caries control, like chemical measures, nutritional measures, and mechanical measures. Chemical measures. Substances which alter the tooth surface or tooth structure. For example, fluoride, iodide, bisbiguanides, silver nitrate, zinc chloride, and potassium iodide. Substrate which interfere with the carbohydrate degradation through enzymatic alteration, like vitamin K. Substances which interfere with the bacterial growth and metabolism, example urea and ammonium compounds. Then chlorophyll and nitrofurans, antibiotics and caries vaccine. Nutrition measures reduced consumption of refined carbohydrates, phosphates, pyridoxine, fat, tannic acid, xanthines, and constituents of coca. Mechanical measures prophylaxis by dentist, tooth brushing, mouth rinsing, dental flossing, oral irrigators, detergent food, chewing gum, pit and fissure sealants. Coming to levels of prevention. Levels of prevention in the general epidemiology, we have covered what is primary prevention, secondary prevention, and tertiary prevention. So, preventive services, this is service provided by individual. Like for example, like our health educators, like those who work in, like health educators or school dental nurse, they can do this type of prevention. In the health promotion, which is the primary prevention, diet planning, demand for preventive service, and periodic visit. In the specific protection of primary prevention, appropriate use of fluoride, oral hygiene practice. Then in the secondary prevention, that is early diagnosis and prompt treatment, that is self-examination and referral use of dental services. So these people, health educators or dental technicians, sorry, therapists, they can do this. Then tertiary prevention, disability limitation, use of dental services. Then rehabilitation includes use of dental services. That means disability means it's already fractured tooth due to decay, so they have to go for dentist to go for prosthesis. That includes disability and limitations. So under primary prevention, that is health promotion, dental health education program promote of lobby efforts. In specific protection, water fluoridation of various school fluoride supplement program. In the secondary prevention, early diagnosis like periodic screening, referral, provision of dental services. This is services provided by community. That's whatever we go and do in the camps. If there is already tooth is like grossly destructed, then we will refer to dental college. So this is, you have to remember, this is service provided by community. How the community can give the prevention. The previous was how health educator. The next one is how the dentist or dental clinic will provide the prevention. Under primary prevention in the dental clinic or by the dental professionals, under health promotion, patient education, then teaching proper brushing technique and diet counseling, and we can do caries activity test also. In the specific protection, topical and systemic fluoride supplements, pit and fissure sealants. And in the secondary prevention, that is early diagnosis, complete examination and prompt treatment of incipient lesions, then preventive resin restoration and pulp capping. So these are things we can do in the secondary prevention. In the tertiary, like complex, in the disability limitation, complex treatment like RCT extraction. In rehabilitation, RPD and FPD. So in this way, we can promote the health services by professionals, those who are affected with caries. For those who are affected with caries. Then caries risk assessment. I think in your oral medicine, you are using some proforma to find the risk of individual. So risk assessment is to predict if new caries lesions will develop or if any early lesions continue to grow, is to assess the caries risk. Preventive actions can be directed to those having high risk for caries, and scarce resources can be properly utilized. Assessment is highly indicated in populations where large portion is caries free, but some individuals are still highly caries active. Risk indicators. Circumstances indicate increased caries risk, socially deprived, no work, bad economy state, then factors related to general health, several diseases or treatments that affect saliva secretion, then epidemiological factors or circumstances which may indicate increased caries risk, living in high DMF country, area, family, high past caries experience. Clinical finding which may indicate increased caries risk, example early sign of disease, exposed root surface, crowded teeth, deep fissures, retentive sites caused by dental treatment. So World Health Organization estimation of global dental caries. According to WHO, estimation of global DMFT for 12-year-old children reported that in 188 countries included in their database that on global basis 200,335,380 teeth were either decayed, failed or missing among just that age group. This was based on the data available in 2004 from the WHO Oral Health Database, Country Area Profile Program. This is why WHO continues to advocate that efforts to improve overall situation are still highly indicated. Malaysian National Oral Health Plan 2011 to 2020. Oral health of school children has improved remarkably since 1971. Oral health of preschool children is of concern where caries prevalence has declined but mean DFT has not shown a similar decrease from 1995 to 2005. This suggests an increase in burden of oral disease, increasing caries severity in smaller proportion of young children that can be identified as high risk group. In adults, increasing caries experience and prevalence with increasing age is noted from 1990 to 2000. However, within that 10-year period, the mean DMFT decreased for the younger age groups of 15 to 19, 20 to 24, 25 to 29, and 30 to 34. Recommendation: early caries experiences, that is caries status in the primary teeth, has been proven to be reliable predictor of caries experience in permanent dentition. Children having caries in their primary teeth were found to be 3 times more likely to develop caries in their permanent teeth. Thus, toddlers and preschool children with persistently high caries prevalence and increasing caries severity are groups where the profession need to redirect more concerted effort to reduce the morbidity from the oral disease. The Millennium Developmental Goals as well as other international declarations have advocated for improved oral health targeting to reduce dental infection among children. In the meantime, our government is also given how to promote the health of geriatric patients, that is elderly patients. So you can refer MOH website to know how to promote the elderly patients, those who are affected with dental caries. And thank you.